Now we are going to start the esophagus. First of all, we are going to discuss questions related to anatomy. So, esophagus. First question, what is the normal length of esophagus? The normal length of esophagus is 25 centimeter. What is the extent? It is C6 to T11. So you can see this is esophagus. The normal length is 25 centimeter, and what is the extent? It's C6 to T11. Esophagus is having three constrictions which are seen on endoscopy. So there are three constrictions seen on endoscopy. And what is the landmark from which we are going to measure those constrictions? It's the upper incisor. So what are those? It is at 15 centimeter, at 25 centimeter, and at 40 centimeter from upper incisor. Now what are the landmarks for these constrictions? Mnemonic is bald. B means beginning of esophagus. And what's the beginning? Cricopharynx. This is cricopharynx. A means arch of aorta. L means left bronchus. And D means opening in the diaphragm. So three constrictions. B is beginning. Is the beginning or cricopharynx. Beginning or cricopharynx. A, this A and L. A, arch of aorta, and left bronchus, and D is diaphragm. It's diaphragm. So this is 15 centimeter, 25 centimeter, 40 centimeter from upper incisor. These are the sites of constrictions. After that, what is the lining of esophagus? Which epithelium? It is lined by squamous epithelium. What kind of? Stratified, non-keratinized. So it is squamous epithelium, stratified, non-keratinized. After that, there is muscle. In the upper 1/3 there is stratified muscle. In the lower 1/3 of esophagus there is smooth muscle, and in middle 1/3 there is slow transition from stratified to smooth. So see the muscle in upper 1/3, there is stratified muscle. In lower 1/3, there is smooth muscle. And in middle 1/3, there is transition from stratified to smooth. So transition from stratified to smooth. These are the questions related to epithelium. After that, lots of questions are asked that what are the structures or what are the layers which are missing. So what are the things which are absent from esophagus? So can you see there is no serosa in esophagus. There is no serosa. There is no Meissner's plexus. There is no villi, and there are no secretions. So in esophagus all these things are absent. Can you see? No serosa, no Meissner's plexus, no villi, no secretions. It means there is only one nerve plexus, and that is our back plexus. If so many things are missing or absent, what is the unique feature of esophagus? The unique feature of esophagus is what? Presence of lymphatics in lamina propria. Lymphatics in lamina propria. This is the unique feature of esophagus. Generally, lymphatics are present in submucosa. You must be knowing lymphovascular supply of the bowel is located in submucosa. But in esophagus, lymphatics are located in lamina propria also. And because of this, what will happen? There is extensive spread of malignancy along the lymphatics in lamina propria, and that's why how much margin we take in esophagus? 10 centimeter. So all these questions are important related to anatomy. After that, see, question is asked, what is the narrowest part of esophagus? The narrowest part of esophagus is cricopharynx, and how much is the diameter? Is 15 mm. And actually speaking, this is not only the narrowest part of esophagus, it's the narrowest part of GIT. So question, what is the narrowest part of GIT? It's the cricopharynx. Narrowest part of GIT is the cricopharynx. So what is the application? If a foreign body passes cricopharynx, generally it is excreted in stool, and we are not supposed to remove it until and unless it's a sharp foreign body. So this is the practical application. So these are the questions related to anatomy. Now first we are going to discuss the congenital condition, and that is congenital diaphragmatic hernia. Congenital diaphragmatic hernia. In short, it's known as CDH. It is also known as Bach-Dalick hernia. Bach-Dalick hernia. It is also known as posterolateral hernia. Posterolateral hernia. Why? Because the defect is there in diaphragm on left side, mainly in the posterolateral direction. So it's the most common type of congenital diaphragmatic hernia. How much is the incidence? Incidence is the 1 in 2000 to 5000 live births. And very important point, what? Bag and mask ventilation is contraindicated. So in this case, bag and mask ventilation. So bag and mask ventilation, it's contraindicated. Now simple question, why it is contraindicated? Because stomach is herniated in the thorax, and if we are giving bag and mask ventilation, what will happen? There is collection of air in the stomach. Stomach is distended with that air, and it is going to compress the ipsilateral lung. That's why it's contraindicated. Now see the etiopathogenesis here. What is the problem? You can see this is the diaphragm. This is the thoracic cavity or pleural cavity, and this is peritoneal cavity. Initially, there is a canal known as pleuroperitoneal canal. So this is pleural cavity, and this is peritoneal cavity. So there is a canal known as pleuroperitoneal canal. Ideally, the pleuroperitoneal canal is going to obliterate, but see what happens if it is not going to close. So failure of, what is the problem here? Failure of fusion of this pleuroperitoneal canal. Can you see? If there is failure of fusion of this pleuroperitoneal canal is going to occur, in that case what happens? There is communication between the pleural cavity and peritoneal cavity. So what is the problem? Can you see the organs here? Stomach, this is the spleen, and this is the colon. Which colon? Transverse colon. So these organs, can you see? These organs are going to herniate here. So these organs are going to herniate where? In the thoracic cavity. And if the organs are going to herniate in the thoracic cavity, it is going to compress the ipsilateral lung. So there is compression of ipsilateral lung. What will happen? Heart will shift to the right side, that is dextrocardia, and the patient will be having scaphoid abdomen. So see the problems. It is characterized by failure of fusion of pleuroperitoneal canal. Pleuroperitoneal canal. What are the characteristic features? It is characterized by triad of mnemonic is triad of RDS. RDS full form respiratory distress is the respiratory distress. D, dextrocardia, and S, scaphoid abdomen. Respiratory distress, dextrocardia, scaphoid abdomen. This is the characteristic feature. After that, one question which is frequently asked in pediatrics, that what's the most important prognostic factor? In these cases, the most important prognostic factor. Second question is asked, what's the most common cause of death? So most important prognostic factor as well as most common cause of death. The answer is same. It's the pulmonary hypoplasia followed by pulmonary hypertension. It's the pulmonary hypoplasia followed by pulmonary hypertension. Now see the problem. In this case, there is herniation of organs. So can you see? There is herniation of what? Stomach. There is herniation of what? Spleen. Herniation of what? Transverse colon and small intestine. Because of this, what will happen? The ipsilateral lung is going to collapse. And what? Heart will be shifted towards opposite side. So that is dextrocardia. So question, what are the organs herniated? Organs herniated. So there is herniation of what? Stomach, spleen, transverse colon, and small intestine. These are the organs herniated. Now one question is asked, can you make the diagnosis during antenatal period or during pregnancy? Yes, because the mother is having polyhydramnios. So it is associated with polyhydramnios. It's associated with polyhydramnios. Now after birth, how we are going to make the diagnosis? So diagnosis, generally we are going for chest x-ray, and on chest x-ray what's the finding? So you can see on chest x-ray what you can make out, that there is presence of gastric air bubble and multiple air fluid levels or multiple bowel loops. So in thorax we are going to make out that there is presence of, if the stomach is there, gastric air bubble, and if bowel loops are there, multiple bowel loops. Now how we are going to confirm the diagnosis? Suppose we are going to insert the Ryle's tube. The coiling of Ryle's tube will occur in the stomach, and the stomach is located in thorax. So very important point, on Ryle's tube insertion, coiling occurs in stomach, located in thorax. So this is how we are going to make the diagnosis of congenital diaphragmatic hernia easily. Now how we are going to manage hernia, congenital diaphragmatic hernia? Have a look. What is the definition of hernia? The hernia is abnormal protrusion of viscous are part of viscous through the wall of its containing cavity. So this is also a type of hernia. What is the principle of treatment in hernia? Reduce the herniated organ back, close the defect, and in cases of large defect, use the mesh. Second principle, since there is growth of kids or children, so there is growth of children with age, but there is no growth of mesh. So in cases of large defects in children, we use prosthetic patch at the place of mesh. So see the management here. Reduce the herniated organ back. Reduce the herniated organ back. Close the defect. Close the defect. For large defect, use the prosthetic patch. For large defect, use the prosthetic patch. After that, a question is asked whether sac is associated with congenital diaphragmatic hernia or not. In majority of cases, there is no sac. If sac is there, what? It should be excised. If sac is present, it should be excised. So excision is done. If sac is present, excision is done. Morgagni hernia. What's the other name of this Morgagni hernia? It's also known as retrosternal hernia, also known as retrosternal hernia, also known as Larry's hernia. Larry's hernia. Now it's very easy to understand. It's a rare type of congenital diaphragmatic hernia. Now see, where is the problem? This is the xiphoid process, and on the right side of xiphoid process, what? There is space of Morgagni or space of Larry. Now see, around this xiphoid process there is a tendon of diaphragm. Which tendon? Central tendon. So whenever there is defective development of central tendon, this space of Larry or space of Morgagni is going to enlarge. Question: which vessel passes via this space of Larry or space of Morgagni? Is the superior epigastric vessels. When the space is enlarged, there is one organ which is herniated. So which organ is located in this region? It's the transverse colon. So there is herniation of transverse colon. But the good thing is that most of the patients are asymptomatic and it's diagnosed incidentally on X-ray. So see, it's less common type of congenital diaphragmatic hernia. It is right-sided vessel. Which vessel passes via space of Larry or Morgagni? Is the superior epigastric vessels. Superior epigastric vessels pass via space of Larry, or Morgagni. So via space of Larry or Morgagni. What is the cause? It is caused by defective development of central tendon of diaphragm. So there is defective development of central tendon of diaphragm. Central tendon of diaphragm. And this leads to enlargement of space of Morgagni and most common organ herniated. Most common organ herniated is the transverse colon. Now coming to the clinical features, most patients are asymptomatic. So here, most patients are asymptomatic. and that's why it's diagnosed incidentally. It's diagnosed incidentally on chest x-ray. Incidentally on chest x-ray. So what's the management? The management is again same. We have to reduce the herniated organ back and we have to close the defect. So management, reduce the herniated organ back, reduce the herniated organ back, and close the defect. Close the defect. So reduce the herniated organ back and close the defect. Very similar to congenital diaphragmatic hernia, there is hernia in adults and that is known as hiatus hernia, which is occurring via hiatus, means the opening in diaphragm. So see, hiatus hernia. So what are the types of hiatus hernia? First, type 1. Type 1, it's sliding hernia. It's sliding hernia. It's overall most common. What is type 2? Type 2 is true paraesophageal hernia. It's true paraesophageal hernia. After that, type 3. Type 3 is mixed. It's the mixed paraesophageal hernia. And what is type 4? Type 4 is the paraesophageal hernia with herniation of other intra-abdominal organ, apart from stomach. Apart from stomach, there is herniation of some other intra-abdominal organ. So there are two questions which are asked. Overall, which one is most common? Overall, most common is type 1, that is sliding hernia. And what is the most common type of paraesophageal hernia? So most common paraesophageal hernia is the type 3. These are the questions. Now just have a look of anatomy. So here we can see that this is normal anatomy. This is diaphragm. These are the crural fibers. And can you see here? This is the G junction. And this is what? Fundus. This is G junction and fundus. So ideally, both G junction as well as fundus should be located below the domes of diaphragm. Whenever there is sliding of only G junction above, so this is sliding hernia. And when there is herniation of fundus by the side of esophagus, it is known as what? Paraesophageal hernia. So here you can see the types. Type 1, you can see that in type 1 there is herniation of only G junction. And can you see in type 2 this G junction is located below diaphragm, but there is herniation of what? Fundus by the side. Type 3, which is mixed paraesophageal hernia, so there is herniation of both G junction as well as fundus. And in type 4, here you can see there is herniation of some other intra-abdominal organ, means what? The bowel. And here also there is herniation of fundus because it's a type of paraesophageal hernia. So here we can easily predict the symptoms. Since sliding is there, sliding of G junction, so what is the symptom? In type 1, here there are symptoms of reflux. In type 2, what is the symptom? Since there is herniation of fundus and sometimes it is incarcerated or sometimes there is ischemia, and because of that, because of ischemia, there is abdominal pain. Abdominal pain. In type 3, what are the symptoms? There is both reflux and abdominal pain. So it's both reflux and abdominal pain. And what about type 4? In type 4, there is abdominal pain plus increased risk of complications like strangulation. So there is increased risk of complications. So there is increased risk of complications. Now question is asked, how we are going to make the diagnosis of hiatus hernia? Investigation of choice for diagnosis is the barium swallow. So now in this picture, try to identify that what kind of hiatus hernia is this. Can you see here? There is herniation of fundus by the side of this esophagus. So herniation of fundus by the side of esophagus. So this is what it's true. It is true paraesophageal hernia. So which one? It's type 2, or it's the rolling. It's type 2 or rolling paraesophageal hernia. So here you can easily make out that this is type 2 or rolling paraesophageal hernia. So we can easily make out the diagnosis on barium swallow. After diagnosis, what we have to plan the treatment. Now see, I told you any kind of hernia should be repaired surgically. So since it's a type of hernia, it has to be repaired surgically. Reduce the herniated organ back and close the defect. Now see, we have two routes. One is abdominal and one is thoracic. Which one is preferred? Abdominal route is preferred because it is less painful. After that, there are two approaches. One is open approach and one is laparoscopic approach. So which one is preferred? It's the laparoscopic approach. So see, the treatment is the laparoscopic hiatus hernia. Laparoscopic hiatus hernia repair via abdominal route. So it's laparoscopic hiatus hernia repair via abdominal route. This is the treatment option for hiatus hernia. Now there is one problem, especially in sliding hernia. Can you see? In patients of sliding hernia, because of sliding of this G junction up and down, there is presence of one ulcer near lesser curvature. So what's the name of this ulcer? It's known as riding ulcer, also known as Cameron's ulcer. So it's riding ulcer, also known as Cameron's ulcer. What is the location? It is located at G junction, located near G junction, near lesser curvature, near lesser curvature. And what is the good thing? It heals spontaneously after hiatus hernia repair. So it heals spontaneously after hiatus hernia repair. Question: it is associated with which type of hernia? It is associated with sliding hernia. Sliding hernia. After that, there are certain questions which are also asked related to named ulcers in the stomach. And these named ulcers in the stomach are stress ulcers, also known as stress gastritis, also known as hemorrhagic gastritis. So see, what are these ulcers? Stress ulcers, also known as stress gastritis, also known as hemorrhagic gastritis. Hemorrhagic gastritis. So these are named ulcers. First is Cushing ulcer. Cushing ulcer. This Cushing ulcer is seen in head injury patients. Seen in head injury patient. After that, curling ulcer. This is seen in burns patient. Patients of burns. So how much body surface area should be involved in burns so that patient is going to develop the curling ulcer? When more than 1/3, when more than 1/3 of body surface area is involved. More than 1/3 of body surface area is involved. There is curling ulcer. Now question is asked, what's the most common site of stress ulcer or stress gastritis or hemorrhagic gastritis? In certain books it's written that duodenum, first part of duodenum is the most common site, but it's a common sense question. Can you see? It is stress gastritis. It's not the stress duodenitis. It is the stress gastritis. So what is the most common site? Obviously it's the stomach. Why? Because maximum acid or acid is being produced from stomach. These stress ulcers are related mainly to the acid production. Now see, from which part of the stomach there is maximum acid produced? Now see the parts of stomach. You can see this is what? Fundus, this is body, this is antrum, and this is pylorus. Now acid is being produced by parietal cells, and the maximum concentration of parietal cells is seen in proximal part of stomach. And what's that? Fundus. And that's why there is maximum incidence of stress gastritis. Stress gastritis is in fundus, followed by body, followed by antrum, followed by pylorus. Sometimes fundus is not given in the option, then go for body. Not given, then go for antrum. Not given, go for pylorus. So you have to choose the option closest to the fundus. After that, if the question is asked, what's the most common site in duodenum? Most common site of stress gastritis in duodenum. So it's the first part. It's the first part, followed by second part, followed by third part, followed by fourth part. So most common site in duodenum is the first part, followed by second part, followed by third part, followed by fourth part. So you have to read the question carefully. What's the language and what are the options provided? Nowadays, lots of questions are asked about upper esophageal sphincter and lower esophageal sphincter in anatomy. So have a look about the questions related to upper esophageal sphincter and lower esophageal sphincter. So first question, what's the normal length? Normal length of upper esophageal sphincter? It's 4 to 5 centimeter. And what's the normal length of lower esophageal sphincter? It's the 5 centimeter. After that, how much is the normal pressure of upper esophageal sphincter? So upper esophageal sphincter pressure is the 60 mmHg. How much is the lower esophageal sphincter pressure? LES pressure is the 6 to 26 mmHg. After that, the total length of lower esophageal sphincter is 5 centimeter. It is divided into two parts. One is intra-abdominal length. So how much is the intra-abdominal length? The intra-abdominal length of LES is 2 centimeter. After that, questions are asked that in upper esophageal sphincter, what are the muscles which are included? So the components here, there are 3 muscles which are included. First of all is the distal portion of inferior constrictor. Distal portion of inferior pharyngeal constrictor. Inferior pharyngeal constrictor. Second, there is cricopharyngeus. Cricopharyngeus and circular muscles of proximal esophagus. Circular muscles of proximal esophagus. So this is a hot topic in the latest exam, upper esophageal sphincter and lower esophageal sphincter. So first we are going to discuss the problems related to lower esophageal sphincter. Lower esophageal sphincter is a smooth muscle. So there are certain drugs which are going to relax the smooth muscle and it's going to decrease the LES pressure. And when LES pressure means lower esophageal pressure, sphincter pressure is going to decrease, what will happen? Patients will be having signs and symptoms of reflux. So first question, what are the drugs decreasing LES pressure? Drugs decreasing LES pressure. And what is the mnemonic? Mnemonic is PMT BD can decrease LES pressure. So PMT-BD can decrease LES pressure. So see, PMT-BD can. PMT-BD can decrease LES pressure. So what is P? P is prostaglandin. It's prostaglandin. E1, E2 and progesterone. M is morphine and meperidine. It's morphine and meperidine. T is theophylline. B is barbiturates. It's barbiturates. D is diazepam and dopamine. Diazepam, dopamine. C, it's calcium channel blockers. A, atropine and N, nitrates. Atropine and nitrates. So all these are the drugs which are going to decrease the LES pressure, and because of this decrease in LES pressure, what happens? There are symptoms of reflux. There are certain food substances which also decrease the LES pressure. So what are the food substances decreasing LES pressure? Mnemonic is caps fat. Caps fat decreases LES pressure. So what's the full form? C. C is chocolate coffee. It's the chocolate coffee. A, it's alcohol. P, peppermint. S, smoking. And fat, fatty food. Fatty food. So these are the food substances. These are the substances which are going to decrease the LES pressure, and after taking these substances, what happens? There is decrease in LES pressure and there are symptoms of reflux. So the patients who are actually having gastroesophageal reflux disease, we advise them not to take these substances or decrease the content of these substances. After that, one question is asked about what is incompetent LES. So what is the definition of incompetent LES? See, this is lower esophageal sphincter. This is dome of diaphragm. Normally, what's the total length? It's 5 centimeter. What's the intra-abdominal length? 2 centimeter. So whenever the total length is less than 2 centimeter, and whenever this intra-abdominal length is less than 1 centimeter, and whenever this LES pressure is less than 6 mmHg, this is known as incompetent LES. And when the patient is having incompetent LES, that patient will be having signs and symptoms of GERD, and that is what? Gastroesophageal reflux disease. Gastroesophageal reflux disease. What's the cause? Here, incompetent LES leads to gastroesophageal reflux disease. Now see the problem here. This is esophagus, this is stomach. What's there in the stomach? In the stomach, there is acid. And if there is acid, what will happen? Can you see? Because of this reflux, there is reflux of this acid where? To the esophagus. And when there is reflux of this acidic content in esophagus, there is esophagitis. So see the sequence of events in GERD. Here, there is reflux of this acidic content. So because of this GERD, what happens? There is esophagitis. Because of this esophagitis, what will happen? There is ulceration. After that, there is fibrosis. After that, there is stricture. After that, there is columnar metaplasia. What's this? It's the columnar metaplasia. And what's the other name of this columnar metaplasia? It's the Barrett's esophagus. Be careful, it's Barrett's esophagus. And you know, this Barrett's esophagus increases the risk of which malignancy? Adenocarcinoma. So these are the sequence of events from beginning till the end. So how this GERD can progress to the adenocarcinoma. Now see the problem. Whenever there is reflux of this acidic content into esophagus, patient is going to develop the symptoms. So question, what are the clinical features of GERD? It is characterized by classical triad of, there is classical triad of, first there is retrosternal burning pain, retrosternal burning pain, there is epigastric pain, and there is regurgitation. So the most here, the classical triad is retrosternal burning pain, epigastric pain, regurgitation. After that, question is asked, what's the most common presentation of GERD? So most common presentation of GERD, and that is history of long-standing heartburn, with shorter history of regurgitation, So this is the most common presentation. So these patients are generally complaining of that they have retrosternal heartburn. This is the most common presentation, and after that patient might develop complications, and the sequence of events we discussed just now. Now, how we are going to make the diagnosis? So see, diagnosis. Question. Investigation of choice for diagnosis is the 24 hours ambulatory pH monitoring. So 24 hours ambulatory pH monitoring. On this ambulatory pH monitoring, we are going to calculate one score. And what's the name of that score? It's Demeester score. So on this pH monitoring, we calculate Demeester score. And generally, this Demeester score is less than 14.7. It's normal. In GERD, what is the problem? In GERD, this score is more than 14.7. It's more than 14.7. Now, how we are going to manage the patients of GERD? First, the lifestyle modification, that's cessation of smoking, decreased caffeine intake, and patient should avoid heavy meals just before lying down. So see the management. First we go for lifestyle modification. So what are the components here? Cessation of smoking, decreased caffeine intake, and avoidance of large meals. Just before lying down. This is one lifestyle modification. For symptomatic improvement, what we give? For symptomatic improvement, what we give? We give double dose of PPI, double dose of proton pump inhibitors. So we give double dose of PPI for symptomatic improvement. By the way, before performing surgical treatment, 3 investigations are mandatory. So what are the 3 investigations mandatory before performing surgical intervention? 3 mandatory investigations before surgical intervention. Surgical intervention. First, we have to confirm the diagnosis by 24 hours pH monitoring. So confirm the diagnosis by this 24 hours of pH monitoring. Second, we have to rule out sliding hernia, because in sliding hernia also there are symptoms of reflux. And what is the investigation of choice? It's the barium swallow. So second is barium swallow. Why we want to go for barium swallow? To rule out sliding hernia. And what's the third investigation done? It's the endoscopy with biopsy. Why we want to go for endoscopy plus biopsy? Because we want to rule out what? Barrett's esophagus. So to rule out Barrett's esophagus. We have to perform endoscopy with biopsy. So these are the 3 investigations which are mandatory before surgical intervention. Now see, it's very important. If a patient responds to PPI, it means the chances of improvement in symptoms are very high after surgical treatment, and that's fundoplication. So what's the gold standard? Treatment for GERD? Is the laparoscopic Nissen fundoplication. So it's the laparoscopic Nissen's fundoplication. Now see how this fundoplication is done. So in this, what you can see that I'm taking the part of fundus behind esophagus and part in front, and both of these parts of fundus, can you see, it is plicated in front of esophagus. So this is fundoplication. And can you see here, almost whole circumference of esophagus is covered. So this is 360 degree. What are the various types of fundoplication? The types of fundoplication: first is Watson. Watson is 90 degree anterior. Second, it's Door, 180 degree anterior. Third, Toupet. Toupet is 270 degree posterior. Fourth is the Belsey Mark IV. Is the 270 degree anterior. And fifth is Nissen's fundoplication. Is the Nissen's, and that is 360 degree. Now what is the most commonly performed fundoplication worldwide? Is the Nissen's. Is the most commonly performed fundoplication. Most commonly performed fundoplication. Nowadays we are not performing this Watson and Belsey Mark IV. So question, what is the most commonly performed partial fundoplication? What do you mean by partial fundoplication? Where whole esophagus is not covered with the fundus. So Door and Toupet are most commonly, these are most commonly performed partial fundoplication. Partial fundoplication. Now see the images. So here in the first one you can see that this is the esophagus, and almost whole circumference of esophagus is wrapped up by this fundus. So this is how much? This is 360 degree. And what's the name? This is Nissen's. So this 360 degree is Nissen's. And can you see here, there is coverage of esophagus only half, and that also anteriorly. So what is this? This is Door, and this Door is how much? 180 degree anterior. So in these two pictures you can easily make out that which one is Nissen's. This one, because it's 360 degree. And what's the name of this one here? You can see here it's 270 degree posterior, and this 270 degree posterior is which one? Toupet fundoplication. So these are the named fundoplications which are frequently asked in exams. Now in detail we are going to discuss upper esophageal sphincter. So have a look. Upper esophageal sphincter. So here you can see that there is oblique fibers of thyropharyngeus, and there is transverse fibers of oblique fibers of thyropharyngeus, transverse fibers of cricopharyngeus. And in between this thyropharyngeus and cricopharyngeus, can you make out that there is a dehiscence? Here there is a dehiscence. And what's the name of this dehiscence? It's known as Killian's dehiscence. Now see below cricopharyngeus. If you can see below cricopharyngeus, there is another dehiscence, and that is known as Lemmer's dehiscence. So Killian's dehiscence is located above cricopharyngeus, and the Lemmer's dehiscence is located below cricopharyngeus. Now here you can see in the lateral area, in this region, can you see? Laterally you can see below cricopharyngeus there is another diverticula. The area is Killian-Jamieson area, and if there is a diverticula here, this is known as Killian-Jamieson's diverticula. This is Killian's dehiscence. Here there is herniation of only mucosa and submucosa, and what's the name of this diverticulum? It's Zenker's. So can you make out this Zenker's diverticulum is located above cricopharyngeus, you can see, and this Killian-Jamieson diverticula is located below cricopharyngeus, and these diverticulas are placed laterally. So see the various types of diverticula in the esophagus. Here you can see this is the diaphragm. This is known as Zenker's diverticulum. This is Zenker's diverticulum. This is mid-esophageal. It is located in middle of esophagus. So this is mid-esophageal diverticulum, and this is known as epiphrenic. Just above diaphragm, epiphrenic diverticulum. What is the other name of mid-esophageal diverticulum? It is also known as traction diverticulum. It's known as traction diverticulum. Why it's known as traction diverticulum? See, because in the mediastinum there is lymph nodes, and these are involved in histoplasmosis or tuberculosis. And whenever there is inflamed lymph nodes in histoplasmosis or tuberculosis, and after that what happens, there is fibrosis, it is going to cause the traction on the wall of esophagus. And when there is traction on the wall of esophagus, it is going to pull the whole esophageal wall. It means in traction diverticulum there are three components of diverticulum. What? Mucosa, submucosa and muscularis propria. Whereas in Zenker's diverticulum and epiphrenic there is only mucosa plus submucosa. Here also there is only mucosa plus submucosa. So this question was asked in AIIMS that there is only one true diverticulum in esophagus, and which one is that? It's the traction diverticulum or mid-esophageal diverticulum. So be careful, this is true diverticulum. What's the meaning of true diverticulum? Which contains all the three layers, that is mucosa plus submucosa plus muscularis propria. Whereas Zenker's and epiphrenic diverticulum is false diverticulum. Why? Because these contain only mucosa and submucosa. So in detail we are going to discuss the Zenker's diverticulum. So first question, Zenker's diverticulum. This is the most common type of esophageal diverticulum. It's the false diverticulum. Why? Because it contains only, there is only mucosa plus submucosa. This Zenker's diverticulum is more common in elderly diabetic males. It's more common in elderly diabetic males. So it's more common in elderly diabetic males. Now see, what's the problem here? So in this patient you can see that there is oblique fibers of thyropharyngeus, there is transverse fibers of cricopharyngeus, and there is Killian's dehiscence. And why are this Killian's dehiscence? There is herniation of mucosa and submucosa, and this is what? Zenker's diverticulum. This is Zenker's. So what is the problem in Zenker's? See, so when this patient is having meals, what will happen? Little amount of food and fluid will be collected into the diverticulum, and because of this what will happen? There is regurgitation, there is aspiration, and what happens? The patients are having halitosis. So what are the clinical features? These patients are initially asymptomatic. Later patients are going to develop halitosis, there is regurgitation, and there is aspiration. Now see the problem. If there is aspiration, what will happen? The aspiration leads to what? Pneumonitis. And after pneumonitis, what's the problem? There is lung abscess. It leads to lung abscess. Question is asked, what's the most common complication of Zenker's diverticulum? The most common complication is the lung abscess. Now see, there is chronic inflammation going on in the diverticulum, and because of chronic inflammation going on, it increases the risk of one malignancy. So which malignancy? There is increased risk of squamous cell carcinoma. What is the investigation of choice for diagnosis? Here, the investigation of choice for diagnosis is the barium swallow. So see how it looks like on barium swallow. So investigation of choice for diagnosis is barium swallow. After that, what's the treatment? There are multiple treatment options. By the way, treatment of choice is, what's the treatment of choice? It's the cricopharyngeal myotomy plus diverticulopexy. So it's the cricopharyngeal myotomy plus diverticulopexy. This is the treatment of choice. By the way, what are the other treatment options? We can go for diverticulectomy. Or we can go for Dohel-Mann's procedure. Dohel-Mann's procedure. What is this Dohel-Mann's procedure? It is the endoscopic stapling. Can you see this diverticulum? So what I'm going to do, I'm going to perform the endoscopic stapling between the septum. Endoscopic stapling of septum located between diverticulum and esophagus. So this is endoscopic stapling of septum located between esophagus and diverticula. How it's done? Have a look. So here you can see that I'm going to perform the endoscopic stapling of septum between the diverticulum and esophagus. And after that, what will happen? Can you see the diagram? The diagram is something like this. And when I perform this endoscopic stapling, after that what will happen? I'm going to establish the communication between diverticulum and esophagus. So what's the name of this surgery? When I staple this septum, since I'm creating communication between diverticulum and esophagus, the name is diverticuloesophagostomy. So what is the other name? Can you see? What is the other name of Dohel-Mann's procedure? Other name of this Dohel-Mann's procedure is known as diverticuloesophagostomy. So it's known as diverticuloesophagostomy. Now we are going to discuss very important topic, and that is motility disorders. Motility disorders of esophagus. So first question, what's the most common motility disorder of esophagus? It's the achalasia cardia. So first question, what's the most common motility disorder of esophagus? And it's the achalasia cardia. It's achalasia cardia. Second question, what's the most common hypomotility disorder? Most common hypomotility disorder of esophagus, and the answer is same. What? It's the achalasia cardia. After that question is asked, what's the most common hypermotility disorder? Hypermotility disorder of esophagus, and this is nutcracker's esophagus. It's nutcracker's esophagus. And next question, what's the most painful Question: most painful motility disorder. So most painful motility disorder of esophagus, and answer is same. What? Nutcracker's esophagus. So these are 4 commonly asked questions related to motility disorders. There is one common point in motility disorders. What? That investigation of choice for diagnosis of motility disorders is what? Is the manometry. So investigation of choice for diagnosis is same in motility disorders, and that is manometry. So first of all, we are going to discuss achalasia cardia. Achalasia cardia. Now see, what is the meaning of achalasia? Achalasia means fail to relax. So fail to relax. So which structure is not relaxing here? It is characterized by absence of LES relaxation. So it is characterized by absence of LES relaxation. Now see, what's the problem here? Have a look. You can see that this is LES and this LES is not relaxing. Why? See here. I told you that in esophagus only one nerve plexus is there, and that's R back. Mesenter's plexus is absent. In R back plexus, there are two kinds of neurons. One is stimulatory and one is inhibitory. These stimulatory neurons are responsible for what? Contraction. And inhibitory neurons are responsible for relaxation. So question: there is selective loss of which neurons? Obviously inhibitory. So it is characterized by selective loss of, there is selective loss of inhibitory neurons. Leading to absence of LES relaxation. So this is the problem, right? Now coming to the clinical features, have a look. First, it is equally common in males and females. So generally, there is no gender variation. Now what is the problem? You can see here, this LES is not relaxing. And if this LES is not relaxing, whatever the food, whatever the fluid patient is going to consume, it's collected where? In the esophagus. So see the problem? The food and fluid is collected into the esophagus. And because of this, what will happen? There is discomfort of swallowing. So what is the most common symptom in achalasia cardia? What is the most common symptom? Is the dysphagia. And you can see here, food is not able to enter stomach easily. So what will happen? There is weight loss. So most common symptom is dysphagia followed by weight loss. Now be careful, this dysphagia is more common to liquids. It's liquids followed by solids. Why? Because liquids take only 7 seconds to reach LES, whereas solid takes generally 9 seconds. Now what is the problem? When liquid reaches early at LES, it creates some kind of pressure, discomfort. So what happens? There is dysphagia. So it is more to liquids as compared to solids. Certain books has written that it's equal to liquids and solid, but be careful, it's not more in solids as compared to liquids. So it's more commonly, or dysphagia is more commonly seen with liquids as compared to solids. Certain book says equal to liquids and solids, but it's not more commonly seen with solids. So as compared to solids, more commonly seen with liquids. Now what is the problem? You can see the whole esophagus is filled with food and fluid. And if this whole esophagus is filled with food and fluid, what are the symptoms here? It is characterized by a triad. So what are the components of this triad? there is dysphagia, regurgitation, and weight loss, So question, how to remember this triad? Mnemonic is draw. So dysphagia, regurgitation and weight loss. So this is the triad. Now see what is the problem here. There is aspiration because esophagus is full with liquids, food content. Because of this aspiration, what's the problem? There is aspiration. Because of that, there is pneumonitis. And because of that, what happens? There is lung abscess. So just like Zenker's diverticulum, in this case also, what's the most common complication? Here also, the most common complication is lung abscess. Now second problem, because of this chronic inflammation going on in esophagus, it increases the risk of one malignancy. And which malignancy? Is the squamous cell carcinoma. So there is increased risk of squamous cell carcinoma. There is a condition which is associated with achalasia cardia, and that's known as AAA syndrome. What's that? AAA syndrome. It's also known as L-Groove's disease. L-Groove's disease. So what are the components of AAA syndrome? A means achalasia. There is achalasia, A lacrima, and ACTH resistant. There is ACTH resistant adrenal insufficiency. There is ACTH resistant adrenal insufficiency. So there is achalasia, A lacrima, ACTH resistant adrenal insufficiency. So these are the components of AAA syndrome. I told you, what is the investigation of choice for diagnosis of any motility disorder? Is the manometry. So here also it's the manometry. Investigation of choice for diagnosis, it's the manometry. Now see, what are the findings of manometry which are characteristic here? First is LES related, and second is esophageal body related. So obviously LES related, there is absence of LES relaxation, and there is increased LES pressure. What about esophageal body related? There is absence of peristalsis, there is ineffective contraction, and there is increased intraesophageal pressure. So investigation of choice for diagnosis is manometry. After that, if we are going for barium swallow, what are the findings? See, on barium swallow, what are the findings? There is bird beak appearance, there is pencil tip appearance, and there is rat tail appearance. Bird beak appearance, pencil tip appearance, rat tail appearance. How it looks like? Now you can see here, there is bird beak and rat tail appearance, and these appearances are same. different names for the same appearance. It means bird beak, pencil tip or rat tail appearances. It is used interchangeably with each other for the same appearance. Certain books also says that rat tail appearance or sign is seen in carcinoma esophagus, but exactly speaking, there is rat tail filling defects. See, in carcinoma esophagus, there is rat tail filling defects. So there is rat tail filling defects in carcinoma esophagus. So diagnosis is generally made on manometry, and these are the characteristic appearances on barium swallow. After that, question is asked that what are the types of achalasia? Achalasia is of two types. Types of achalasia. It is of two types. One is primary achalasia, which we described, and the second is secondary achalasia. Secondary achalasia is also known as pseudoachalasia. It is pseudoachalasia. So you can see what is the problem in primary achalasia. There is absence of inhibitory neurons in the Auerbach plexus. This secondary or pseudoachalasia means it is secondary to known causes. It is secondary to known causes. So question, which causes? Generally it is because of malignancy and because of Chagas disease. Chagas disease. So this is secondary achalasia. Now what is the pathophysiology in achalasia cardia? That this LES, which is a smooth muscle, is not relaxing. So we have to work on pathophysiology. So we have to give the relaxant. What? Calcium channel blockers or nitrates, or you inject the botulinum toxin. Second, you can go for forceful dilatation, or you can divide the sphincter like what we do in the Heller's cardiomyotomy. So see the management options. Management, first we give drugs, the drugs which can relax the smooth muscle, like we give calcium channel blockers and we give what? Nitrates. Calcium channel blockers and nitrates. Second option, Botox injection. Third option, balloon or bougie dilatation. So we go for balloon or bougie dilatation. What is bougie? Bougie is a metallic dilator which is going to forcefully dilate the LES, and it is going to rupture the circular muscle fibers. But what is the treatment of choice? The treatment of choice is laparoscopic Heller's cardiomyotomy. Laparoscopic Heller's cardiomyotomy. Question, why it's known as cardiomyotomy? Because the myotomy is extended till cardia, or 1 centimeter to the esophagus. So this myotomy is extended. Now why it's known as cardiomyotomy? Can you see? Because the myotomy is extended till cardia, means 1 centimeter of stomach. So cardiomyotomy means myotomy is extended till 1 centimeter of stomach or cardia. Now see the problem. Whenever I'm going to divide the sphincter, what will happen? It's going to open, and because of this, patient will start having symptoms of reflux. So after laparoscopic Heller's cardiomyotomy, we have to go for fundoplication, but be careful, not the complete fundoplication, we go for partial fundoplication. So after Heller's cardiomyotomy, we perform partial fundoplication, and I told you which types, either door or toupee, fundoplication. Nowadays we also perform POEM for achalasia cardia. What is the full form of POEM? full form, it's per oral endoscopic myotomy. So it's per oral endoscopic myotomy. This is poem performed for achalasia cardia. So see how this poem is performed with the help of endoscope. Can you see? We create a tunnel, and via this tunnel, what we do? We perform via this tunnel. We perform what? The myotomy. So via this tunnel we perform the myotomy. Only natural orifice is used. So it's a type of nodes. What is the full form of nodes? Natural orificial transluminal endoscopic surgery. So per oral endoscopic myotomy is a new treatment for achalasia cardia. Now see, in chronic cases, what's the problem? In chronic cases, esophagus loses its tone and motility, and it's massively dilated. It's massively dilated. This is known as mega esophagus, also known as sigmoid esophagus. So mega esophagus or sigmoid esophagus. And in these cases, what's the treatment? We perform esophagectomy. So in chronic cases where there is mega esophagus or sigmoid esophagus, we perform esophagectomy. Now before discussing diffuse esophageal spasm, I want to tell you two things. First, what are the types of esophageal contractions and what's the blood supply of esophagus? First, see what are the types of esophageal contractions. Esophageal contractions are divided into three types. First, primary, secondary and tertiary. It's primary, secondary and tertiary. Now what are these contractions? Have a look. Whenever we eat something, what happens? Just after swallowing, there is peristaltic wave starting from cricopharynx and it travels till GE junction. So it's the progressive contraction which propels the food bolus into stomach. After that, during its passage, some amount of food is going to stick to the walls of esophagus, and that irritation starts another peristaltic wave or contraction, that is secondary. But the tertiary contractions are non-peristaltic spasmodic contractions. So have a look. This primary contraction is the progressive contraction. It's progressive and it's triggered by voluntary swallowing. And it reaches LES in 9 seconds. I told you. After that, this secondary contraction, again it's the progressive contraction. It's progressive contraction. It is triggered by distension or irritation. This is triggered by esophageal distension or irritation, but not by voluntary swallowing. And what is this tertiary contraction? Be careful, it's non-progressive and it's non-peristaltic. It's non-progressive and it's non-peristaltic contraction. So these are the types of esophageal contractions. After that, have a look of blood supply of esophagus. Be careful, esophagus is a parasite. It's not having its own blood supply. So the area where it passes, it receives the blood supply from that particular area or region. Can you see? It starts from lower part of neck. So it receives blood supply from thyroid. Which artery? So it is supplied from inferior thyroid artery in the neck. After that, when it goes in thorax, what happens? It is generally posterior to bronchus. That's why it is supplied by bronchial arteries. After that, below T4, it is anterior to what? Aorta. So it is supplied by direct branches from aorta, and near dome of diaphragm it is supplied by inferior phrenic artery, and near GE junction it is supplied by left gastric artery. So this is the blood supply. Now see how these vessels are going to supply the esophagus. These vessels are going to penetrate the muscularis at right angle, and after penetrating the muscularis at right angle, these are going to supply the esophagus. Now see the problem. If in the esophagus there is tertiary contraction or spasmodic contraction, what will happen? Its blood supply will be cut off temporarily. And if the blood supply is cut off temporarily, so what will happen? There is ischemia, and ischemia will lead to pain. So what will happen in diffuse esophageal spasm? When there is non-peristaltic contraction or spasmodic contraction, there is spasm of esophagus leading to ischemia and leading to pain. Esophagus is located on which side of chest? Left side. So it leads to left-sided chest pain, and this mimics angina. That's why most of these patients are initially referred to cardiologist, but be careful, most of the cardiovascular profile ECG is normal, then only these patients are referred to the surgeon. So see, diffuse esophageal spasm. Diffuse esophageal spasm. It is caused by tertiary contraction. Tertiary contraction of esophagus leading to spasm, leading to left-sided chest pain, and dysphagia. So you can see here, what are the clinical features? The clinical features are left-sided chest pain and dysphagia. Question: what is the investigation of choice for diagnosis? And we already discussed, it's what? Manometry. Nowadays they are asking the diagnostic criteria also. Now can you see? This is the amplitude, and the amplitude is more than 120 mmHg, and this is the duration of contraction. It's more than 2.5 seconds. So the amplitude is more than 120 mmHg, and duration of contraction is the more than 2.5 seconds. So this is the diagnostic criteria. By the way, if we are going for only barium swallow, what are the findings? So this is the finding on barium swallow. So what's the name of this appearance? So on barium swallow, there is corkscrew appearance. Corkscrew appearance. It is also known as rosary bead appearance. Rosary bead appearance, also known as pseudo diverticular appearance. Pseudo diverticular appearance. These are the findings. Now here, what is the problem? There is spasm, so we have to use what? Antispasmodics. So see, management. Here we give first antispasmodics. So what we have to give here? We give generally calcium channel blockers and nitrates. And for non-responding patients, what we have to go for? In these patients, we go for esophagomyotomy. So for non-responding patients, we have to go for esophagomyotomy. Next is very important. It's the nutcracker's esophagus. Nutcracker's esophagus is the most painful motility disorder. So it's the most painful motility disorder of esophagus. It is characterized by, what are the symptoms? Here also there is chest pain and dysphagia. So it is characterized by chest pain and dysphagia. Obviously, how we are going to diagnose it? I told you that investigation of choice for diagnosis is the manometry. And see, on manometry, what's the diagnostic criteria? Here, the amplitude is more than 180 mmHg and the duration of contraction is more than 6 seconds. So diagnostic criteria: first, amplitude of contraction more than 180 mmHg and duration is more than 6 seconds. Diagnosis is done. Here also we have to use antispasmodics. So what's the treatment? Generally we have to use antispasmodics, same agents, generally calcium channel blockers or nitrates, and in non-responding patients we can go for esophagomyotomy. So for non-responding patients we can go for esophagomyotomy. So this is how we manage the patients of motility disorders.